Sophie.
Start, doctor.
Good evening, colleagues, ladies and gentlemen. On behalf of my colleagues in the organizing committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the globe to this webinar. This webinar is organized in collaboration with NMC Specialty Hospital Dubai and is sponsored by Vita Biotics UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali, who is always helping us. Well, this webinar is entitled Headache in Children. We have eminent speaker and panelists. In a short while, I'll be introducing them. Well, as usual, there is a question. Who is this gentleman? Those who answer, they will get a token of appreciation and name will be announced. 4 conditions associated with his name. So please, if you know, you mention. Beautiful Dubai. This is the best time to come to Dubai. Climate is good. One of the most beautiful cities in the world. And as I mentioned earlier, his ruler, His Highness Sheikh Mohammed bin Rashid Al Maktoum said, I want Dubai to be number 1. Inshallah, in many aspects, it is number 1. Well, as I mentioned, today we are having eminent speaker and panelists with our moderators. Our speaker is Dr. Vivek Mundeda, Senior Consultant Pediatric Neurologist at Medcare Hospital and Clinic Groups, Dubai. Our panelist is Dr. Muhammad Nami, well known to all of you. He was in our previous webinars. He is a clinical cognitive neuroscientist, associate professor of neuroscience and cognitive neuropsychology at American University of Dubai. He is also the managing director of Brain Hub Clinic in Jumeirah, Dubai. Well, our moderators, Dr. Kalpana Sen Gupta, well known to all of you, Secretary of the club, and Dr. Diari Mohammed, Chairman of the Academic Affairs. I'll be introducing them later. On behalf of all my colleagues and members of Dubai Pediatric Club and members of the organizing committee, Dr. Joshi, Dr. Kalpana, Dr. Diari, Dr. Amir, Dr. Ayman, Dr. Rafia, Dr. Bandari, Dr. Leila, and Dr. Khaled Rashid. Once again, I would like to invite you to this webinar about our future events. Well, next month on 22nd November 2024, we will have our 10th annual Dubai Pediatric Club Symposium. We will have eminent speakers and we have organized good sessions for you. Don't miss, please save the date. Well, our 11th annual Dubai Pediatric Club Conference and Workshop will be on Saturday and Sunday, 17th and 18th May 2025. Detail will be announced later. Well, our sponsor, Dr. Tawfiq, Country Business Manager of New Country Health and Vita Biotics, we would like to thank him once again. Well, briefly, I would like to mention about a history of headache and migraine. In a very short time, 10 to 15 minutes, I'll finish it. Well, always I start in the memory of Hippocrates, the father of medicine. As I always say, everything starts with Hippocrates and ends with Hippocrates. And the famous quotation, first do no harm. Well, headache and migraine, I would like to briefly mention about the migraine first. The word migraine is from Greek hemicrania, pain in the half of the head, from hemi, half, and crania, skull. A 2nd century description, but by Aretius of Cappadocia, divided headache into 3 types: cephalalgia, cephalia, and heterocrania. See, this is of 2nd century. And Galen, the famous scientist, used the term hemicrania, half head, from which the word migraine was eventually derived. Just to remember. Well, some ancient treatments of migraine, it is interesting to know. The first and most popular was trepanning. Trepanning is a process of drilling the holes into the skull to alleviate the pressure and pain. Burning the head. They used to burn the head, very painful. Applying leeches to the forehead and putting a dead mole, this is mole, animal, on the head. Bathing with eels. Eels is a type of fish they used to put. Soaking feet in hot water to draw blood from the head. Running around the house 3 times. This is the easiest. Rubbing the head with a stone containing iron ore. Wrapping damp clothes around the head and burning scented wood. It wasn't until around 1925 that ergotamine became the first medicinal treatment available for the treatment of migraine. Just to remember, interesting. Well, briefly about the drug development, it wasn't until 1868 that the use of a substance, which eventually turned out to be effective, began. What was that? This substance was fungus ergot, from which ergotamine was isolated in 1918 and first used to treat migraine around 1925. Then later on, methyl sergite was developed in 1959, and the first triptan, sumatriptan, was developed in 1988. Well, detail of the latest advances from 20th century and 21st century, I'm not going to details Dr. Vivek mentioned. Well, this is a beautiful painting by Vincent van Gogh, the famous Dutch, actually the painter who died in France at the age of 37. This painting is called Starry Night. When he was in jail in France, he drew this. And you see these strokes, he has severe migraine. And during these severe attacks of migraine, he drew this picture. And if you see, these are all because of the migraine attack. Well, about headache in ancient terms, the history of headache and neuroscience goes to as early as 7000 BC before Christ. Trepanation, as I said, the removal of a segment of the bone from the skull was very widely performed. Trepanation may have been performed to release demons and evil spirits from the head. Ancient men believed these spirits were the cause of headaches and disorders such as madness and epilepsy. Well, trepanning was still recommended by some 17th century physicians for the treatment. The famous William Harvey. Who is William Harvey? The person who discovered blood circulation. In 1660, even William Harvey recommended trepanation of a patient with intractable migraine. It was very popular till recently. Well, credit goes to Egypt and Egyptians. Eber Papyrus. Eber Papyrus was medical writings of ancient Egypt, dating back to about 1200 BC and named after professor of Egyptology. Mentioned migraine, neuralgia, and shooting head pains, and is said to be based on earlier medical documents from around 1550 BC. The Egyptian, this is interesting, please note, the Egyptian would firmly bind a clay crocodile, holding grain in its mouth, to the head of the patient using a strip of linen. The linen bore names of the gods whom the Egyptian believed could cure their ailment. I have experienced it. Many people are still using it. In actual fact, the process may have relieved the headache by compressing the scalp and possibly collapsing distended vessels that were causing the pain. It's very helpful. Well, this is the one. They used to put a clay crocodile on the head and with a string wrap it with pressure and just pray. Very interesting. Well, as I said, everything starts with Hippocrates. Hippocrates around 400 BC was the first to describe visual symptoms of migraine, especially on the right side. Hippocrates also noted the association between headache and various activities such as exercise and intercourse. 400 BC. Well, about the ancient Greek and Roman scholars, headache have long been attributed to digestive disturbances. Please note this is also interesting. And to the flow of bile, one of the digestive juices. Almost 2000 years ago, the Roman physician Galen commented the pain ceasing when the bile has been vomited. That is why when the patient is having severe migraine, they vomit, and this vomiting relieves the pain. Hippocrates realized that vomiting, when possible, could partially relieve the pain of headache. The vomiting attacks of childhood, often migrainous in nature, are still referred to as bilious attack. Just remember. Well, in nutshell, from 7000 BC, as there was evidence of neurosurgery, came to Eber Papyrus, classification of migraine, then Hippocrates describing the visual events, and then went to the Roman physician Galen in nutshell. And this is about trepanation, making hole in the skull, which was very popular. Well, few points about Razi. Razi, also known as Razi, who was in 9th and 10th century, a famous Iranian physician, devoted an entire chapter to headache in his book. His work described in detail one of the different types of the headache, now known as migraine clusters. Another scientist, Ibn Sina, also known as in the West as Avicenna, who also lived in 9th and 10th century, another Iranian famous physician, wrote a chapter on headache in his book, Qanun of Medicine. Actually, this is Qanun. Since the European cannot write it, it is then canon, means principles of medicine. Well, then it went to the Germany, the German, there was a lady in Germany that Hildegard of Bingen, the other was Hildegard von Bingen, Germans they call it. A German medical writer. She could visualize and the aura visions. I mean, able to replicate her visions in the form of aura. European medieval treatments of headache included drug soak poultices applied to the head with opium and vinegar. It is interesting to know why vinegar. The vinegar in solution was probably used to open the pores in the scalp, allowing the opium to be absorbed quickly through the skin. Well, this is also in nutshell how it started and went to the European part. Who is this gentleman? Thomas Willis. I would like to draw the attention of all neurologists to note that 300 years later, in 1672, Thomas Willis introduced the term neurology. So neurology is introduced by Thomas Willis is famous for circle of Willis in the brain. In anatomy we read. Willis was aware of the many causes of migraine attack, including heredity, changes of the season, atmosphere changes, and diet. Willis also introduced vascular theory of headache. And it is interesting here that in 1770, Erasmus Darwin is the grandfather of Charles Darwin. Charles Darwin was one of the people who suffered severe migraine. Julius Caesar also had this thing, Jefferson, others. Proposed the theory of treatment by centrifugation. Very painful. They used to put the patient and centrifuge. Well, Edward Living was an English physician who published a theory of migraine pathogenicity in his book called On Megrim in 1873. Leving published on Megrim, sick, headache, and some allied disorder, the contribution to the pathology of nervous storm. So his view was that the nervous storm was the cause of this. And this view differed from the vascular theory proposed by others. But in scientific era, William Gower, now our question, the person in question was Sir William Gower, known as one of the famous founders of the modern neurology and an eminent physician in late 90s, subscribed to the neurogenic theory of headache as advised by Leving. In 1888, Gowers published the most influential textbook of neurology at the turn of the century, a manual of diseases of nervous system. Very famous. Till recently, it was followed. In his passage for the treatment of migraine, Gowers emphasized the importance of diet. We are now emphasizing, he said, Gower also invented headache treatment that came to be known as Gower mixture, the solution of nitroglycerin in alcohol. Interesting. Well, this is Sir William Gower, known as the founder of modern neurology. He was a British neurologist described by MacDonald Critchley. MacDonald Critchley was a very famous neurologist in London in 1948 as probably the greatest clinical neurologist of all time. Well, this is just in a nutshell how the things I explained evolve. I'm not going through it. And in 20th century, Paul Ehrlich, the first professor of pediatrics in Europe, who worked on immunology, he got the Nobel Prize in 1908. And in late 1960s, Harold Wolff was the first person to study headache in laboratory and about the vascular theory of the headache. Well, in a nutshell, what happened, I'm not going through it. Well, now we are coming to our speaker and panelists. Well, as I said, our speaker is Dr. Vivek Mondeta, Senior Consultant Pediatric Neurologist at Mediclinic Hospital Group, Dubai, and our panelists, Dr. Muhammad Nami, MD, PhD, Clinical Cognitive Neuroscientist, and Assistant Professor of Neuroscience and Cognitive Neuropsychology at Canadian University of Dubai, and Managing Director of Brain Hub at Jumeirah, Dubai. Well, our moderators, Dr. Kalpana Sengupta, Senior Consultant Pediatrician and Head of Department at NMC Specialty Hospital, Dubai. She is Secretary of the club. And Dr. Diari Muhammad, Senior Consultant Pediatric Surgeon at Ad Jalila Children's Hospital, Dubai. He is Chairman of the Academic Affairs of Dubai Pediatric Club. Where about our speaker, Dr. Vivek. Dr. Vivek is a British certified pediatric neurologist. He is a consultant pediatric neurologist at Mediclinic Hospital and Clinics, Dubai. After graduating in India, he trained and worked in the UK and acquired CCT from the Royal College of Pediatric and Child Health. His work in acquired brain injury was appreciated as London model in the House of Lords in 2017. He moved to the UAE in 2019 and has been associated with Dubai Pediatric Club since the beginning of his career in Dubai. He has been pioneering in gene therapy and has been active in this field since 2020. He serves on the Global Advisory Board for the companies like Novartis, Sarepta, Roche, and Pfizer in this field. He has been academically active, serving as faculty for many international and national conferences. He is faculty for the courses like Pediatric Epilepsy Training and Childhood Headache by the British Pediatric Neurology. Interesting to know, Dr. Vivek is very good singer. He was singing in Expo 20 and he is one of the winners of the Dubai Pediatric Club in singing section. Very good singer. My references, thank you very much. Now, I would like to request Dr. Vivek to start his presentation, and I would like to request all viewers to write their question in Q&A box. After his presentation, we will start the session. Dr. Vivek, please.
Thank you very much, Dr. Shorab, and all the members of the Dubai Pediatric Club to invite me. Just a brief background, I've been telling Dr. Shorab because I serve as the faculty on a course called CHAT course, which is a childhood headache course, which runs like throughout the day, whole day. And, it was very interesting because this course is designed for pediatrician. We have a eminent psychologist here, so I should not utter this, but there's something called Dunning-Kruger effect, because more and more, Dr. Shorab has already told us about the history of the headache in last centuries, and as we move toward 21st century, we have been knowing more and more about this condition, and things get more and more simplified because then we realize our root, like history and examination, is the core strength, which we should not forget. If you see the new classification of epilepsy, they're very simplified. We used to say complex partial and so on, but now it's a nomenclature. And same is happening with the headache. And I know there have been a lot of investigation people used to do for functional neuroimaging and so on. But as I said, we have moved on to our roots of history and examination, and that's what the core message I'm going to give you when we deal with any child with headache. And this presentation, I have tried to make it more simplified and more kind of a clinical oriented, because we see these cases every now and again. I'm sure you all as a pediatrician see at least, one child daily with the history of headache. Now, and it's very interesting because let's say there is some teenage child who comes in my clinic and I ask, okay, how many types of headache do you know? And they'll say, okay, 3 or 4 types of headache. But then if I say that, if you go through the International Headache Society's classification, there are more than 200 different types of headache. If I'm more precise, 217 headache types that we know of. And that becomes a bit complex. But what we're trying to do is subclassify the headaches to make it more and more simple so that the management can be targeted accordingly. So, of course, I can't go through the each and every part of the headache. We'll have to just focus on the very common presentations of the headache, how to take the history, examination, and how do we classify, briefly about the management that we can do in the day-to-day practice. And so the outlook, I'll tell about the presentation. But before that, I've just tried to, because I love interaction. I love, talking to live audience. Now that we're doing a webinar, I thought I'll ask some live questions, and the way will be interacting. I mean, there won't be a lot of questions. Don't worry about that. But I'll put a QR code on the screen. All you have to do is grab your mobile, scan the QR code. There'll be question on your screen. You have to answer live, and we'll just see the answer on the screen. So don't worry, there won't be many difficult questions today. It's just from the daily practice, what you see in the clinic. So the brief outline of my talk today is why it's important, bit of epidemiology in today's times, classification of the headache, very, very important. And the most core part of the presentation is history and examination, because you'll realize that by taking good history and examination, you'll come to conclusion and diagnose many different types of headaches, especially the primary headache. Migraine, bit of them, because they again fill up more chunk of the headache clinic. Tension type headache, they are more common than the migraine. Something about chronic daily headaches. And secondary headache is itself is a big chapter. So I probably won't go through that today, because otherwise we will be consuming almost half of the night here. So if I sit in my clinic, we usually get like 1/4 of the adolescents suffer at least weekly headache. If you ask those who have children, teenagers and adolescents, they'll at least complain dull headache or tension type headache. What we know is it's the second most common cause of years of life spent with disability worldwide. And not only that, if you compare the quality of life, it's even worse than asthma and diabetes. I'm sure those who have migraine in the audience can relate to this sentence. And despite we see a lot of children with complex headaches. Now that I tell there are more than 200 different types of headache, we kind of try to make it more simple. Of course, they are simple, but sometimes we feel that there is a low rate of referral. And this comes from the evidence as well. And effective treatment options are not always offered, and that we always see in the clinic, especially when the children get referred to us. In terms of epidemiology, there are a lot of studies now in terms of epidemiology, regional studies, worldwide studies. But if I combine in terms of prevalence, let's focus on the migraine. So what is the prevalence in children? Because that's what we are interested in. So the overall prevalence is just over 5 to 6%. But if you see the graphs, it's, both the age groups, less than 14 years or up to 20 years, it's more common in the girls. The younger girls, of course, has around 7%, whereas the older girls, the adolescent girls and the young adults, it's above around 8 to 9%, less common in the boys, but overall prevalence is anywhere between 6 to 7 to 7.5% in general population in children we're talking about. Whereas when it comes to tension type headache, the 1 year prevalence data that we know, so in 7 to 15-year-old, and that's combined male and female, it's around 10% more than migraine. Whereas in older age group, 13 to 8 years old, it's around 18%. And again, similar like migraine, they're more commoner in female than the male. And of course, as I said, tension type headache we see very often in migraine. They get misdiagnosed as migraine as well. So it's very important to take correct history and examine these children so that we can categorize them in an accurate bracket. How do we classify the headache? Now, the important message or take-home message I want to give today is either the first step we have to do when we see the children in the headache clinic is to say whether the headache is primary headache or secondary headache. Even if we do that, we can avoid unnecessary investigations because the investigation will come into picture when you diagnose secondary headache, and we have to focus on the etiology. Whereas primary, of course, comes from history and examination. There is no investigation needed. So that's the first question we should be asking in terms of classification. And where do you see the classification? What is the Bible of classification? If you have to go to website and just Google ICHD for me, it's called International Classification of Headache Disorder. We're on the 3rd version. The 4th version will be coming soon. It was released in 2018. Now, if you go that, I've told that there are more than 200 different types, but the classification is more for the research. But again, I get that reference most often in the clinical practice as well. I love to show the website to the older children, the adolescent as well, and they get mesmerized. Okay, why do I say you have tension type, or why do I say migraine? And I kind of ask them to go, and because it's open for public as well, if you go to just Google ICHD, and it used to be beta, now it's a 3rd classification. Now, what my message to all of you is, be familiar with the classification and use the criteria for diagnosis of the common headaches. It's very useful a very useful website. If you, let's say, open tension type headache, and it will give the criteria when to call tension type, when to call migraine, and there are sub-classifications and sub-classification. So just a reference today, and this is the base for today's presentation as well. However, as I said, there are more than 200 classifications. We don't need to know all of them. In our clinical practice, this is kind of my classification because we see these cases more often. So of course, as I said, you have to confirm it's a primary headache or secondary headache. If it's a primary headache, most commonly seen is tension type headache, then migraines, then the the autonomic headaches, of course, like cluster headaches and so on, and others. We'll come to that in the end. In the trigeminal autoimmune cephalgia or headaches, you get cluster headaches or paroxysmal hemicrania, whereas in migraine, you get either migraine with aura or migraine without aura. And the other types of headache, like primary stabbing headache, it's not very rare unless you ask specific history. But I get these children sometime in the clinic, giving the primary history of primary stabbing. We'll just have a few slides on that. And the other, of course, is a secondary headache. As I said, I'm not going to touch base on the secondary headache today. The whole focus will be primary because that's a major chunk what we see in our clinic. And the most important part, as I said, is history and examination, because by this, doing a thorough history and thorough examination, we will be getting to know whether the headaches are primary or whether headaches are secondary, and a little bit of subclassification as I showed in the previous slide. Why is history so important? So if you see the evidence, the first study back in 2003, and this stands true even today, cases of 150, the headache history provided the correct diagnosis and management in all 150 cases. They didn't have to do an investigation, just the thorough history. The other, the study which was in Hull, Dr. Abu Arafe in North England, he runs a headache clinic there, and he had a cluster, it was a retrospective kind of analysis he did of 815 cases. And out of these, if you see the proportion of secondary headache, were just 3 cases, and all were predicted from history, because these 3 cases, then they moved on to do the investigation, and others were primary. So you see the importance of history. You can actually categorize the headaches into primary and secondary by taking thorough history as well as examination. Now, we have in the chat course, and we also practice in day-to-day life, because we all are busy clinicians and we have to ask specific questions. So there are some mnemonics that we have formed here, and the way I say it's liquid FOE, or LIQDFOE. The first part, I'll just go one by one, is a location. Where does it hurt? Is it generalized? Is it side locked? Is it focal? Which area of the head? Intensity. Now it's very different and difficult. It's subjective as well. Younger children, you may not be able to identify the intensity, but sometimes the child is sitting in front of your clinic and smiling and giving the history, and they'll be saying, oh, I've got the headache as well. It's a mild headache. Whereas sometimes the child is intensely in pain. You can see the pain score as our nurses do that. And can predict in the younger children. Of course, the older children can tell you about, you can give the scale. It's just your imagination, your way of practice, out of 10, out of 5, whatever. The quality is because, again, if you go to ICSD, the quality of pain is different in different headaches. For example, it could be pulsatile quality in migraine, or it could be just very dull aching, just like a tight rubber band in tension type. It could be a stabbing quality in primary stabbing, boring, very kind of a throbbing pain in cluster headache. So quality helps us to come to conclusion what type of headache. Again, younger children, it can be very, very difficult. The duration of the headache, does it last like few seconds or few hours or few days? There are histories of like status migrainosus and so on. Frequency, of course, it's important for us to know in the headache world, anything more than 15 episodes per month is called chronic. And that's why, to classify that as well, frequency is very important. Others, if there is associated nausea, vomiting, photophobia, phonophobia, getting worse with the physical aptitude, that kind of history is very important. Effect, if you again go to WHO ICF classification, the participation or effect of any disease is very, very important. You take any disease and how does it affect your participation is important. So we use different scale like PEDMEDA scale, or a different question, how many days of days you missed in the school, can you perform your hobbies, because that if that has negative impact on your quality of life, then of course the headache is very, very severe. It's just not the episode, but the headache disorder, then we need to focus on. Not to forget, like in any child or any other history, you have to go through all the details, but the focus is on the psychosocial history as well, because these are the triggers as well as these are the effect. Chronic headache will cause issues like depression and anxiety in a teenager, and vice versa. And that can be attained with various scales. We use RCATs and so on. I'm not going to go in detail again, but a basic history can be important. Education, how many school days you have missed because of the headache, attendance, the achievement, attainment, social life and family, and so on. So this is just a brief outline of how we ask the history, headache specific history, as well as general history related to the headache. Now, what is also important is how the child is between the attacks of the headache. So let's say if there's a complete recovery between the headaches, then it's most likely your primary headache. However, if you have any other symptoms, like there is an academic decline, or there are any visual difficulties, if there are neurological symptoms, episodes of vomiting, or if the headache severity goes on increasing with time, then of course you can't say for sure that they are primary headaches, because that's probably hinting towards a secondary headache. And that's why this history also between the headache attack is important as much as the headache history. This is important because when it comes to management, you are going to tell them exactly the same point, because the thing before which comes before medicine are these points. you ask the history and something will be irregular in the history. So like sleep, the amount and regularity, the time they sleep, it should not be kind of variable. Someday 8 o'clock, someday midnight. Regularity is very important, and the quality of sleep overall is important. Skipping meal is one of the very common trigger factors for migraines. Dehydration. Now, this factor I see most often in children in Dubai. They take this, the water bottle, they get it back. The mothers will say, "Oh yeah, 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 the child just the same," and you have to encourage them to drink plenty, especially in the summer months. The screen time, of course, is very important. It's a big elephant in the room. The school is more very much on the screen, and the children spend a lot of time on the screen. But you have to encourage them to be active. The nature of exercise, as Dr. Shora briefly mentioned, there's a type of headache which is exercise induced. Of course, that comes with the history, but then you don't get that much, the incidence of that part. But if the children are not active, the sedentary lifestyle can also induce the headache. So that part of the history has to be included in your history taking as well. Next important part is examination. Now, after history, of course, we examine the children. This is also an important part of headache history taking and coming to conclusion, because what does the evidence say? Now, this is the study back in 2001. What it says is 18% of this 180 children included in the study with the headache attending the emergency department had serious underlying pathology, and all of these could be identified neurological sign. So what it shows is their incidence of secondary headache was almost 18%, but they could identify that with the neurological sign. So if you examine these children, if you have abnormal neurological sign, you are sure that these children have some secondary headache. Of course, that's in combination with the history. Whereas, the red flags, which you see, the prevalence. Now, brain tumor, this is the big elephant in the room. When children are brought to clinic with the headache, the parents have this kind of fear. Will you be doing the scan? Does my child have the tumor? Does it have? And so on. But if you see, the brain tumor headaches are associated with abnormal neurological signs. You don't have silent, just the headache as the history in the brain tumor. You should have something along with that. At least in my experience, I've never got pure headache presenting as a brain tumor. But you have like almost 85% within 8 weeks of the onset of headache, and in all children as they move on with time, because you should have vomiting and so on. And this is why examination is important and complementary to your history taking. What do we examine? So, not to forget any neurocutaneous markers, just general examination. Cut marks again can be indicator of depression, suicidal ideation, which could be leading to headache, and headache leading to that part as well. Scalp tenderness is one of the criteria for tension type headache, because the pathophysiology is kind of, very cutaneous. So that you have to feel the scalp. You have to check for any CNS abnormalities, ataxia or focal neurological signs. Then the neck range of movement and tenderness, again, very common in the chronic headache. You get that neck stiffness in any chronic migraine or chronic tension type headache. TM joint is often missed during the examination. It's very easy. You put your thumb or finger on the TM joint and ask the child to open. If you get the clicking sound or pain or tenderness, it's a time to refer to the TM specialist, oral surgeon, maxillary oromax surgeon. And eyes, again, most of us, I'm sure, they refer to the ophthalmologist in terms of, just getting it thoroughly checked, whether it's giving rise to any secondary headache. And of course, your nurse would be doing the height, weight, blood pressure, BMI, pubertal staging, because if the child is having faltering growth on the growth chart and so on, then they are most likely secondary headache, and these children need neuroimaging. Let's move on to the first type of migraine, which is a big chunk. There's a lot of research going on in the field of migraine. They have a good pathophysiology. We have enough understanding of pathophysiology now, and that's why the treatment is more targeted towards those pathophysiology and the mediators in that inflammation. So what we know so far is they have the genetic predisposition. Now, I've seen that, most often the parents say, "Oh, I had the migraine in my childhood. Does my child have migraine?" Not necessarily, because it's a polygenic condition. Unless you move on to hemiplegic migraine, they are more kind of a monogenic condition. Then they have more kind of a genetic basis. But yeah, you can have genetic predisposition migraine running in the family, but not necessarily. That's not the compulsory part in the history. You can have sporadic migraine, multifactor inheritance. And family history is again very common. As I said, the familial hemiplegic migraines, they have more kind of based on to genetic. We know more genes. You get gene panel now to diagnose hemiplegic migraine, CACNA1A and ATP1A3 and so on. Now, what we know is the abnormal activity in the brain which causes the migraine comes from predisposed genetic, environmental, metabolic background, which we know as triggers, the environmental factors. That kind of induces an array of neuroinflammation in the brain. And one of the important factor is CGRP. Now, because I'm just mentioning because there are new modalities of the treatment, which is focused on this CGRP inhibitor or receptor antibodies or monoclonal antibodies. It's an area of interest. If you see this, release of CGRP and PACAP, and then you get the migraine attack. So, it's no more kind of just a pure neurovascular etiology. It's more complex to that. And that's what we get in migraine. This is the classification in ICHD. So it's just not migraine with aura and without aura. But again, with aura, it could be typical or brainstem or hemiplegic migraine, chronic migraine complication. If you're not sure, sometimes you're not sure, you have to send the child back and get the history. So then you can call probable migraine. And the episodic syndromes, which you often see in the younger age group, cyclical vomiting, abdominal migraines, the colic, is just more of a predisposed to this kind of conditions in future. Benign paroxysmal vertigo, benign paroxysmal torticollis, all these are variants of migraine. We're not going to focus on all the conditions. We'll just see briefly one or two subtypes which we more commonly see in the clinic. Okay, let's come to a case. I've got a 9-year-old girl who has got headache for last 6 months. She gets 1 to 2 attacks per month, so almost like 1 in 2 weeks. These attacks last for 24 hours. The pain is severe enough to stop all her activities. She cannot just perform anything when the pain is there. The headache quality, if you ask the history, because you've gone through that liquid 4 classification, the mnemonics, it's a throbbing and mainly bifrontal. There are associated, there's no warning symptom before the headache. Associated symptoms like loss of appetite, nausea. She gets intolerant to light and noise. Whereas she feels better if she takes rest and sleeps, and if she takes painkiller like paracetamol. You examine her and the examination is normal. Now, if I may ask you to pull out your phone and scan the barcode and let me know what do you think the type of headache is. These are the options in front of you. I'll give you half a minute only and let me know what you think. Just scan the barcode which is on the left corner of the screen, or you can open the website Slido and then see that. Very interesting. We have 14 participants so far. So I guess we will have a tie between tension type or migraine. More towards tension type, okay. I'll wait for another 10 seconds or so. 10 seconds, counting down. Okay, so I think most of you think tension type, and that's good because that is why I'm presenting here to make sure that all our doubts are clear. Well, this girl, if I'll just move on, has migraine without aura. Because again, if you go to ICSD classification and see what and when to call migraine without aura, someone should have 5 episodes of headache lasting anywhere between 4 hours to 72 hours, and at least 2 of the following: unilateral location, pulsating quality, moderate to severe. Your tension type headache is always mild to moderate. They are very bilateral and bitemporal rather than unilateral. The quality is different, not pulsating. Tension type are more dull and just like tight feeling headache. One of the characteristic of migraine is they get aggravated by walking or similar routine activity. So you're forced to be still, and you have to have at least one of the following: nausea and or vomiting, or photophobia and or phonophobia. However, life is not that simple, not black and white. Everything is not that black and white. When we see the children, it's very, very difficult to localize and pinpoint all these things. So what happens? Half of the children will complain, even if it's migraine, they're bilateral. So it's not necessary to have unilateral in pediatric population. The quality can be very difficult. As I said, children may not be able to describe you the pain. The intensity again can be, from their behavior, as I was mentioning. We have to understand, is it the mild pain or very severe headache? You can ask this question to the parents, school absence and so on. Issues like, pala, you can see. Nausea is most commonly present in pediatric population, whereas vomiting is almost like 2/3 of the population. And photophobia and phonophobia. So how do you avoid that? You darken the room to avoid the photophobia. Phonophobia is the quiet room. And how do I picture the child? A dark, quiet room, severe headache, and forcing to sit still or lie still because the physical activity can exacerbate the headache. And because this case didn't have any warning sign, that's why we're calling it as a migraine without aura. So I'm sure it's clear now, because as I said, it's very clear, if you go to ICHD and just refer back when to call them back. Okay. When it comes to with aura, the attack history is now less from 5 to 2 attacks. That's why I've just highlighted in 2. So at least 2 attacks of the headache, and the aura consists of either visual, the sensory, speech symptom, motor, brainstem, retinal symptom. And this aura should have the symptoms developing over 5 minutes or in succession, and each symptom should last anywhere between 5 to 60 minutes. There is at least one aura should be, the same side of the headache, and there has to be positive aura or negative aura. I'm not going to go in detail again of those. And the headache should follow within 60 minutes of the aura onset. And this is when the ICHD calls it as migraine with aura. If you have the classic aura and then followed by the headache, that is your migraine with aura. And it's very important to ask, do you get warning? Because if you don't ask leading question, the children may not say or mention that to you. Okay, now the next question on the screen. So I don't know if you have some participant with migraine, but many of our children, and this is coming from the, we ask them to draw, what do you actually see? Let's say the visual aura is there. It's very common if you ask them, what do you see in front of your eyes? So there are two things. The picture, one is on the left side, one is on the right side. Which one do you think is aura, visual aura with the migraine? Left-sided image or right-sided? I'll come to the later part why I'm asking this question, because again, it's very relevant. What we say, there's another condition where you see this kind of picture. So when it comes to migraine, what do you think is the visual aura here? Left-sided image, which is the colorful, or right-sided image, which is more of a black and white? Again, you will get a barcode. If you just quickly answer that within half a minute, and then we'll see. Yeah, I think the right sided is correct answer, because migraine is more like a black and white wavy lines, whereas the left side image, I'll just go back to the image here. The left side is what we see in the occipital epilepsy. You get this visual kind of thing, more colorful, rounded, concentric circles. That's what you see in the focal epilepsy of occipital origin, or benign epilepsy is one of the benign epilepsies that we see. Whereas this black and white dotted wavy lines, which we see in the migraine. So yeah, you're right. Okay, let's see this case. It's slightly different than our previous 2 cases. This child has had very few episodes, 3 headaches over 1 year. The attack lasts for 2 days, almost 48 hours. Severe throbbing unilateral headache is the history. But what is interesting is there's an aura. There's a weakness of arm and leg. The speech gets slurred, and this can last 4 hours with the headache. So any one side of the arm and leg can get weak. There's associated symptom of nausea, vomiting. There's a photophobia, there's phonophobia. But interestingly, this recovery is spontaneous, and the child stays very well in between the examination, and the examination between the attack is normal. Do you know what this is? I think you have guessed it right, probably, because this is hemiplegic migraine. Now, this particular migraine has a very genetic kind of basis. Here, you can ask the history because it's mostly likely autosomal dominant, but sometimes you can get the sporadic or de novo mutation as well. It's very rare. I've got few children with very refractory cases, but they can have prolonged motor aura, and almost because you're not comfortable just diagnosing primary headache in these children. So when they come in the attack in emergency, when they are hemiplegic, of course you're going to do the imaging. We avoid triptan here because triptan, one of the things they do is a vasoconstriction. So theoretical risk, but again, I haven't seen any case of having infarction, but that's more of a theoretical theory here. Why we avoid triptans in the hemiplegic migraine, but that's a bit of a hemiplegic migraine. How do we manage migraine? It's a big thing topic itself, but we'll just briefly summarize. Now, I divide it into the few parts. The first part is, of course, treatment of the acute attack, because when the child has a headache, you should be giving them the option how to deal with the headaches. And the second part is the headache disorder, not the acute headache, just the headache, where you can space out the headaches, reduce the severity, and that is very important as well, not just treating the acute attack. So similar to how we give the emergency medicine in epilepsy and the prophylactic medication not to have the seizures. So prevention is lifestyle modification. That's the first thing in any headache clinic. That's the first thing you should be talking to the children. Trigger avoidance, anything like sleep deprivation, less drinking, whatever, that has to be avoided to avoid the headaches. And the drug prophylaxis comes in the end when everything you do and the child is still having very frequent headaches, then you can think of drug prophylaxis, but not as the first. It's very important. How do you decide, when to give the prophylaxis? How severe is the headache? Nowadays, it's easy. Previously, we used to use the paper diary, just like seizure diary. We give them the headache diary. We got the apps, just something called Migraine Buddy. There's another app called iHeadache. Now, there are more apps than that. I use this more often. You can share that with the doctors as well. And the children have all they have the phone. You can log the headache on that. You can get the frequency, the typing of the headache, more information on their headache. So headache diary can be useful tool to give to the children. And apps can be one of the things which you can use in the modern days. I told that you have to treat migraine as acute attack, and as well as you have to think beyond that to avoid these attacks. So in terms of treating acute attack, early intervention. So whenever the child has headache, the beginning of the headache, when you give the medicine, you're going to cut down the severity and the duration of the headache. So it's very important. Even when the child has aura, there's a time to start giving the medicine. So rest, as I just showed the picture, because rest can help the children. Avoid aggravating factors like, if there's a photophobia, phonophobia. So switch off the light, dim the light, quiet room, so that, the child feels better. The pain relief has to be early, not after 1 hour or 1.5 hours, as soon as they get, because that is why ICSD says minimum 5 attacks, because you have to be having a stereotypic history of similar attack, appropriate dose. We all know the dose of paracetamol, ibuprofen, whatever, appropriate route. If the child is vomiting, there is no point in forcing the child to give oral. We have triptans, which is given by nasal route and so on. Not to forget antiemetic, because I've seen many examples when the painkiller alone may not be helpful. If you combine that with antiemetic, that can be helpful. So never forget antiemetic in migraines, especially. When it comes to prevention, of course, the one important part in the headache clinic is counseling. If you go to ICSD and just search medication overuse headache, and you see the history of the medicine, paracetamol, ibuprofen, all the medicine can cause medicine overuse. What is it? So if you take very frequent painkillers, that itself can cause headache, chronic headache. So it's very important to avoid them taking painkillers every frequently. So not more than 2 times a week. And that's the kind of a thumb rule I have in my clinic. So avoid medication overuse headache. When you give the prescribe the medication, that's the counseling you're going to tell to your parents. Regular sleep, regular exercise, not skipping the meal, avoiding caffeine like drinks, drinking plenty of water, weight management and being active, and any trigger, and nowadays screen time. So these are the points I always tell to the children, never forget this when we prescribe the medicine. You have to avoid this headache. Follow this routine and come back in the clinic and let me know what is the frequency or the severity of the headache. Many a times you will see that, of course, they get it reduced, and you can avoid the drug prophylaxis, which sits in the end of this, because you're going to keep that option in the end if the frequency is a bit high, despite following all these things. They're very new treatments, and I'll come to triptans in there. We have this triptan called sumatriptan, rizatriptan, zolmitriptan, olmotriptan, which are most frequently used, and they hit the target, which is a presynaptic 5-HT1B or HT1D serotonin receptor agonist. And they inhibit the CGRP release, and that's one of the pathophysiology in the migraine. So that's how they act. However, these receptors 1B and 1D, they can cause a side effect. Children feel the tightness in the chest and vasoconstriction and so on. That's why we have more interest in targeting the selective 5-HT1F receptor. And these molecules are called ditans. Lasmiditan is available in UAE. But it's a bit costly, but can be covered in the insurance. I think the 4 tablet will cost around 400 to 500 dirhams if you want to buy. Much, much costlier than the triptan, but they're very selective and very more kind of effective, seen through the PREEM studies and so on. The new molecules, as I said, the CGRP has been a interest of research in the migraine pathophysiology and migraine management. So you have the small molecule which are receptor antagonists, so that the CGRP doesn't hit the receptor, and these are called gepants. So rimegepant and abrogepant and zevagepant, all these gepants are licensed about 12 years of use. Slightly costly. Some of them are available in UAE. There is a monoclonal antibodies which acts against CGRP receptor, erinumab, currently available in UAE. It's a kind of injection you give monthly to avoid the headaches, costing more than 2,000 dirham if you want to buy, sold by Novartis again. And the other ones are monoclonal antibodies, again, the peptide, not the receptor. And again, they're called different kind of, Zumab, what we call it as. So all these new medications are there in the market, most often licensed in older children and the adults. But of course, triptan can be used, as young as, 6-year-old sumatriptan, very safely used and give nice result. If you open the NICE guideline, you can combine the triptan with the NSAIDs and the antiemetic, and the effect can be much, much better. The nasal sumatriptan is also available, those who cannot tolerate oral. So don't forget triptan. What about prophylaxis? We have done the lifestyle intervention. We have dealt with the acute attacks. Now, there are a lot of meta-analysis. There was long back meta-analysis back in 2008 and 9 when nothing was favorable. But if you see even the evidence for flunarizine and look at the study participant, just 21, based on that, they have done that analysis. More often used in the adult. We use propranolol in clinical practice. I've seen pizotifen, but again, that was not, pizotifen is very good drug for abdominal migraine to use. But again, the evidence is lacking in other type of migraine. Topiramate, you can use it, but again, neuropsychiatric side effects can be there. And that's one of the things. But again, there is no right or wrong in terms of the choice of medication. There are a lot of options we have, and it comes with the clinical, but it's important to give the trial for at least, 2 months to 3 months, and then say they're not effective before we move on. The new therapies coming on, the interventional neuromodulation or non-interventional, non-invasive neuromodulation. Like we give the blocks with the local anesthetic in greater occipital nerve block in the chronic migraine. Botox, there are like 31 different spots in the skull where you inject the Botox. They can be implanted in the sphenopalatine ganglion. Deep brain stimulation, very rarely, occasionally used, most often in adult. But what is interesting is non-invasive neuromodulation. So the bottom left is non-invasive vagal nerve stimulation. The device is called GammaCore. Then there's a transcranial magnetic stimulation. There's the ETNS. If you see the third image called Kefeli, it's available on Amazon. If you just see Kefeli, more than 2,000 dirham, and you can just replace that. It's a Bluetooth kind of device that's on the phone. Then the REN, remotely kind of doing the neuromodulation, which you can operate on the phone. Slightly costly. I've used Kefeli in just one girl who didn't want to take any medication. It's kind of a 50 to 60% of response you get in terms of neuromodulation. But yeah, it's just to show you that these kind of therapies are available, which can bypass the medication and can be non-invasive. And if you really are stuck somewhere, then you have an invasive kind of neuromodulation, which we do in the headache clinic. I personally do greater occipital nerve block, but not others. There are other medication which we have been using. There are some with the evidence, some very fleeting kind of a case report, and the nutraceuticals like riboflavin or magnesium or melatonin, coenzyme Q10, which can be given, especially riboflavin has a good evidence now. It sits in the NICE guideline, very high dose, like 400 milligram. Herbal remedies, they don't have enough kind of evidence, but acupuncture has up to 10 sessions if 2 prophylaxis fail. And that's when if you give for 4 to 8 weeks, 5 to 8 weeks, that may be one of the evidence to refer the patient. And I'll come to psychological intervention in a bit. So this is your evidence for riboflavin up to 400 milligram per day. It shortens the migraine attacks and reduces the frequency. High dose vitamin D's, magnesium. Of course, magnesium has side effect like diarrhea if you use it, carefully. Melatonin has now evidence, but mostly in adults and so on. So psychological intervention, there is a good evidence to refer the chronic patients to psychologists. We have the expert here, and they may tell later more about that. But CBTs, cognitive behavioral therapy, is one of the very known intervention which can be effective, in the chronic tension type headache, chronic migraine. And there's a lot of evidence to say that, CBTs can reduce the headache frequency, severity. CBT plus amitriptyline can reduce the severity as well as in adolescent if you just give amitriptyline as a prophylaxis. Let's shift the gear and last few slides. A 15-year-old doing his exam, he has headaches that occur 2 to 3 times per week. It's usually in the forehead, relieved by paracetamol or ibuprofen, and is able to continue studying, but finds it a bit annoying. It's just a kind of a dull headache. Again, pull out your phone and let's see what do you think this headache is. Yeah, I think you guessed it right. It's a tension type headache. Why do I call it? And the way I describe tension type headache is it's a characterless headache. It's a very black and white headache. Migraine has all the colorful headache, photophobia, phonophobia, nausea, vomiting. Tension type is just headache. There is nothing attached. It's less precise in characterization, dull, mild. It just bothers. It's not something very severe enough. Less severe pain, less incapacitating, and there are few associated symptoms. Nausea can be present along with the tension type headache, but that's just because of that dullness of the pain. Vomiting is very, very rare in tension type. Again, when it comes to headache, you call it as infrequent episodic tension type headache if you have less than 1 episode per month. If you have 1 to 14, you call it as frequent episodic. That's just the classification. If you have more than 15, then any headache is chronic for you. So again, because of the characterless pain, you have to have 10 or more headaches lasting less than an hour to up to 7 days. It can go up to 7 days. Pressing, tightening quality, bilateral, mild to moderate, pain not aggravated by routine activity because they are then mobile, no nausea, vomiting, no photophobia, phonophobia. And the pathophysiology is different, more of a somatic receptors triggering the headache. And that's why you get the pain or the decreased range of movement in the muscles in the neck if you have a chronic tension type headache. Let's say if you have a 9-year-old boy who has been suffering from very short headache, which just lasts 1 to 3 seconds, that's it. And they happen several times of the day, and he's distressed by them. They're just bothered. I get many children with this kind of history, and he can't just get paracetamol because they have very short acting headaches. And it doesn't sound like migraine because they're very short. I don't know if you have seen any children, because if you don't ask, many of the time you get the children with migraine or tension type headache, but if you don't ask this history, they won't tell because they're very kind of dumped down in the history. They'll be focusing on the severe. But I've got children who only has this kind of headache as well, and they are called. So if this is liquid foia history, the location is variable. It can happen anytime, but they are very sharp. They are stabbing in quality, last in seconds, variable frequency, and no associated symptoms. And these are called as primary stabbing headache. I don't know, sometimes if you eat the ice cream and if you get the brain freeze, suddenly you get the brain freeze. And that's the kind of close description you can have for primary stabbing headache. They're very short, almost sometime associated with tension type and migraine. You can have 2 types of headache in the children. And if it's very severe, multiple attacks in the day, indomethacin is the drug to prevent that. But you can't treat, of course, because it's very short-lived. How about this one? A 10-year-old who has developed a severe left-sided headache during which he's very agitated, hits his head with the fist. That kind of severe headache. His eyes have been bruised. There's none of the painkillers usually work, including codeine, and none works. By the way, I just forgot to tell you, never prescribe codeine to the migraine children or tension type, because it's one of the contraindicated. We don't use codeines. If you see the list, paracetamol, brufen, triptan, but no codeine, please. Okay, so just to give the severity of the headache in this child, and it has some red eye kind of associated on the same side. And if you have guessed this the part right, so this is location wise is orbital, temporal, side locked, severe or very severe, boring quality, drilling quality. Some of the adults relate to that, the labor pain, that kind of severe. It can last seconds to several minutes, variable in frequency, autonomic feature, rhinorrhea or watering of the eye or redness of the eye. And it's very, very disabling headache. And this headache is called trigeminal autoimmune cephalgia or cluster headache. And there are different types, of course, but in a broad term, they're called TACs or trigeminal autoimmune cephalgia. When it comes to management of these headaches, tension type headache, we saw explanation, because that's why I said, you have to reduce the anxiety of the parent. It's not something sinister. It's not something related to tumor, secondary headache, and that really sometimes help. There's nothing wrong with your child. Explanation, lifestyle changes, which we just mentioned, same thing apply in the tension type headache as well. Treatment, simple analgesia, but avoid medication overuse. Please avoid medication use. Otherwise, you're going to end up another different type of headache in your clinic. Prophylaxis can work sometime, but there's no good evidence. The last study on JAMA showed that the placebo was working better than amitriptyline or topiramate. Acupuncture, you can try, of course, just like migraine we thought of. In paroxysmal hemicrania, like the cluster headache, you can use oxygen. They're very specific. Cluster headache, if you diagnose, you have to have subcutaneous sumatriptan for the attacks or high flow oxygen. And anti-epileptic drugs or verapamil can be useful to prevent these attacks. Last few slides, Dr. Shorab, sorry. The other things often parents ask, these balms, the forfeit, they have the ingredient like levomenthol, which can use as a placebo, but they have some evidence in RCTs. I don't know if you've seen this Tiger Balm white powder. They have this menthol, which works on substance P and reduces serotonin, and it only is in white Tiger Balm. This Jandu Balm has capsicane, which acts on the TRPV1 kind of receptor. So there is some evidence to that on the headache management. Just one or two slides on chronic headache. Never say chronic headache. You have to have chronic migraine, chronic tension type. Medication overuse is another type of chronic headache. You have to take the good history of headache. Secondary headache, you can have chronic because they are more than 15 days. But of course, your history can tell if this secondary headache. And you have to have like more than 15 days per month and 3 consecutive months to say the secondary headache. There is a good guide. I personally use this from this website called My Brain First or HeadSmart, which gives a warning sign to say whether they're secondary or you need the imaging or not. Like in the babies, if you have these signs, or children, if you have these signs, or teen, you do this sign. I'm not going to go in detail again, but there's a very good guide. We used to get that as a paper slip, but I used to give to the parents as well. Look for that and come back if you see any of these. And that comes to the end. The big thing when we ask the parent, when to do the neuroimaging. CT scan, we often do in some kind of secondary headache like thunderclap headache, just to check for, let's say, subarachnoid hemorrhage and so on. But most often we end up doing the MRI. And this is if you have certain red flags in the history or an examination, something like abnormal neurological examination. If it's a very recent but severe headache onset, change in the severity of frequency suddenly, if it's a fixed or very unusual location, or early morning, waking up from the sleep, or postural headache, just you get in, let's say, Chiari malformation headaches, abnormal growth or puberty, just to look for the space occupying lesions. If there's a deterioration in the school, work, personality, as I said, the history part, if the child is having something between the headache, and if you can't classify despite taking a good history, then probably you can perform this neuroimaging. Lastly, this was a very short overview of the headache. If you want to get more kind of learning, these are the useful resources of American Headache Society, and there's International Headache Society. I sit on the faculty for British Pediatric Neurology run chat courses. There are virtual courses coming up on 22nd of November and 11th of March. Those who are interested, that's a barcode for you to book. It's a whole day course. It's run like 9 to 5 UK time. So ours is like, 12 to 8-ish in the afternoon. But it's a very good course, not because I'm faculty, but I'm just saying just to give the overview. And that brings to the end of my talk today. And thank you very much for listening. Thank you.
Thank you very much, Dr. Vivek, for this excellent presentation. But I suggest you change the 22nd November because it is our annual symposium. Change that date. Otherwise, we recommend people not to participate. Thank you very much. Now, I would like to request Dr. Nami, Dr. Diari, Dr. Kalpana to join us. I would like to take this permission, since you mentioned in the treatment, psychological intervention. Now, I would like to request Dr. Nami, as an expert in this field, how you approach this type of people, please.
Yeah, sure. Thank you very much. And it's a total pleasure to be contributing to this. And thanks, DPC, for the opportunity. Well, getting to the idea that children with psychobehavioral issues, including depressive symptoms or anxiety-related symptoms, when they have this dysregulation in autonomic nervous system, they might
Nami,
be a
your
kind of,
voice is people little bit.
is it audible now?
Little louder. Yes,
Okay.
yes, thank you.
So when children have this imbalance in their autonomic nervous system dynamics based on psychobehavioral issues that they have, given the underlying mechanisms that they are playing a part causing neuroinflammation in the brain or changes in the dynamics of the neurotransmitters, including dopamine and norepinephrine, we might be having underlying conditions including ADHD or autism spectrum disorder or oppositional defiant disorder cases, poor family function and stuff like that. This may bring in some additional factors that this harmony in the autonomic nervous system will cause sympathetic overdrive. And the sympathetic overdrive may cause some vasoconstriction or vasospastic reactions in the deep vascular, hemodynamics in the brain. And that might reflect in sort of like headache-related symptoms. And when we mitigate the psychobehavioral issues, when we tackle the depression, anxiety, or oppositional behavioral disarray, that will lead to decrease in the neuroinflammatory processes that is an ongoing challenge in the brain. And psychologically, behaviorally, that is going to be doing the trick. On the other side, some children will have like compensatory mechanisms or coping mechanisms that is like maladaptive coping mechanisms. So when they are seeking connection or seeking attention, and there's no way to grab the attention of parents, they just put the hand on the head and they complain of the headache. Now I am having that headache again and again. So it's some sort of like a somatoform projection of the behavioral symptoms as a somatic presentation. We need to take that also into consideration. Tackle and scrutinize the possible root cause of any emotional, behavioral, or cognitive, or motor and sensory issues, and also the family function that they are playing a part in the presentation of the symptoms.
Thank you very much. Now I'd like to request Dr. Kalpana to start the Q&A by asking the questions. Of course, there are a lot more questions to be asked. Please.
First of all, thank you, Dr. Vivek, for this very comprehensive review of headache in children. I think Dr. Nami has already touched upon the autonomic part of it. That was the question from one of the participants about the autonomic symptoms, how important they are, how often do you see these in migraine?
So I think they make a big part of the headaches, like cluster headaches, So one of the things which I forgot to mention, the autonomic symptoms are ipsilateral. That's one of the criteria to the headache. And that can be very different forms. They can have rhinorrhea, they can have lacrimation, they can have congestion, conjunctival congestion. So these kind of autonomic symptoms we do see. Of course, as Dr. Nami has already mentioned, you have associated things as simple as somatization, tachycardia, and the pain-related things are there, but they're not specific to the diagnosis of migraine or other characteristic of the headache. Apart from the cluster headache, they are very typical autonomic symptom. Or you have brainstem aura sometime, that can present like autonomic symptom. So with the aura, that part with migraine or cluster headache, the very small group of headache which can have autonomic symptoms associated.
Dr. Vivek, thank you very much for this nice presentation. So in your practice, what's the most common type of headache you are seeing?
Same tension type headache, very commonly, So they come, my child has migraine. I said, okay, let's not make the diagnosis. Let's be unbiased. Let's go through, ABC and then come to conclusion. Yeah, tension type is very common. It's not uncommon to have two different types, and that is challenging. So we focus, okay, let's part of the severe headache history that can be different than the mild headache history. So you can have mixed headache, but in my experience, and I'm sure most of my colleagues will agree to that, tension type is very, very common than migraine.
Okay, you mentioned in the studies also, sorry, Dr. Kalpana, that females or girls are more than males. This is because of hormonal changes or because what will be the cause?
Kind of a mixed thing. Again, Dr. Nami can focus on that question as well. But yeah, hormonal part, the coping strategy, what they say about the anxiety and the depression. Again, this prevalence, hopefully in the adolescent population, is more in the girls as well. So the associated thing. So yeah, more of a hormonal, the genetic basis. There's no clear answer to that. But just like we see more of a psychological problems, neuropsychiatry problems, sometimes more common in the girls than the boys. It's a similar part of the history, tension type headaches. And also the migraine, we do see more in the females.
Okay.
It's not usually different, but slightly higher than the males, of course.
So in your practice, Doctor, since the management is pretty complex, what percentage of children would really require prophylaxis?
I would say nearly just a quarter, not more than that. Because, the first focus is, of course, you have to bring the children back in the clinic with the headache frequency diary just to see how they are doing. The first advice from my side is, okay, we'll manage the acute headache, but do this part, lifestyle intervention, and now come back, how it works. If somebody is having a headache, let's say once a month or something, they're not the children who need prophylaxis. Of course, if you end up having, a lot of school absentees 2-3 times per week, and the lifestyle intervention doesn't work, these are the children I would put them on drug prophylaxis, not all.
And once started, how long do you continue it?
I think I go for minimum 3 months before I pull it off, just to say if it's effective or non-effective.
May I interrupt to ask one question? One of the important things I advise is the diet.
Yeah.
Some diets like banana, cheese, I mean, these are aggravating factors. There's a list of that which mothers usually ask. You mentioned about the caffeine. I think in 1990 something, WHO gave a chart. What are the food items not to be given? Caffeine. I wrote to them, I said, I am addicted to tea. If I don't take tea, I will get severe headache. They changed the classification. If you see, so those see, because we say this is vasodilation, caffeine causes vasoconstriction. Like I give you an example. If in the class teacher is there, all the students are sitting. As soon as teacher goes out, all children start making noise. So caffeine for those who are used to, I mean, without tea, there are many people not me. If I don't take tea, I get tea. So for those who are not used to, yes, caffeinated may cause, but both those who are taking, this point I wanted to.
So cheese and wines and those kind of triggers are very specific to the individuals. They're not generalized. So we do ask in the history, is there anything, any dietary thing or anything which brings on the headache? And of course you have to, as I was saying in the history and examination, you have to do the trigger management. Definitely the diet is one of the things in that.
I think it is
There is
very
a question
individualistic.
If I
from
can
Dr.
make a very short
Muhammad.
comment on that.
Sorry.
Yeah, sure.
Please.
Yeah, with regards to the tea and chocolate and coffee or caffeinated drinks, as long as they contain this kind of stimulant that they are categorized under a superfamily of substances called methylxanthins, they find their way and they attach to specific receptors, as all we know, adenosine receptors. And we have two types of adenosine receptors in the brain. And there is a very wide array of genetic polymorphism for adenosine reactivity. And the effect generally is like vasodilation at the superficial and meningeal vessels, and vasoconstriction in deep-seated vessels and arteries in the brain. That's why many people that they have migraine, when they drink coffee or tea, they start to have, aggravation of the symptoms. But at the same time, many others, they find it relieving. That's because of the way that the adenosine receptors and ligand of those stimulants will play the part. When we press physical, pressure over the superficial vessels and veins and the arteries on the temples, it will transiently decrease the pain, because actually we are physically making vasoconstriction. But still, that the underlying cause of that disharmony in the autoregulation of the vascular system depends on the vasoconstriction within the circle of villus arteries. And this is one thing that we need to always take into consideration, that it differs person to person based on the genetic array and based on the predisposition to aggravation or alleviation of the symptoms of headache in the face of exposure to methyl xanthines.
Okay. There's a question from Dr. Sudhashri. Please elaborate on postural aggravation of headache.
There are types of secondary headaches, for example, idiopathic intracranial hypertension, very classically, after sitting and lying down, they change. Or there is something like a Chiari malformation. Very classically, you get that on Valsalva maneuvers, like sneezing and coughing. So most often, if you get the history with postural changing of the headache, they're secondary headaches. The IH is very, very common kind of headache you get. Of course, you have vomiting and along with the headache and visual symptoms and so on. But if you get that clear history, that change with posture, you have to think of secondary headache in that case. And these are the cases I would investigate, of course.
As far as the medicines, have you seen any difference? Does Brufen work better? Mefenamic acid works better?
So in adult population, they use a lot of naproxen and even the mefenamic acid. Pediatric population, Brufen for migraine works better than the paracetamol. But again, if the Brufen doesn't work, so I feel triptans are very underused in the pediatric clinics. So they're very good drugs for migraine. If you are very sure that if you diagnose migraine, I don't think we should hesitate to start using triptans. And you can combine that with paracetamol or Brufen. There's a good evidence, again, it's in the NICE guideline also, that you can combine and give it. Those who are not getting relief with Brufen, migraine population, if you ask, those who suffer, paracetamol generally kind of, less effective than the ibuprofen. But of course, mefenamic acid and naproxen are other. But if we ask the simple analgesics which use in day-to-day practice.
May I ask one question till they found? You mentioned about I have seen a lot of articles coming on mindfulness, positive psychology. Of course, you said cognitive behavior. Pioneers like Kabat-Zinn, I think in 1973 started. Then Seligman in 2002 is known as father of positive psychology. Lot of articles like this, meditation coming up. Non-medication. What is your opinion, with Dr. Nami? Elaborate on this.
Yeah, thank you for bringing that up. Well, actually, the mindfulness-based cognitive trainings will help us to have a better grasp on our bodily symptoms in relation with our cognitive and emotional regulations. When people are trained appropriately to practice mindfulness-based exercises, they will have better control on their breathing rate. And we know during the exhalation, we have an increase in a metric in our autonomic nervous system dynamic, which is called heart rate variability, or HRV. The moment that we are focused on the duration of our exhale and inhale and the time that we keep the breath held, and this is called controlled breathing, we will enhance the heart rate variability. And heart rate variability is a surrogate marker which informs us how dominant the parasympathetic nervous system is putting sympathetic drive into balance. So based on that, many things will happen. Number one is that the ongoing stresses and motives for the cognitive and emotional dysregulation are going to be less disruptive, number one. Number two, there is less of sympathetic overdrive inputs to the brain, which is going to lessen the impact of pro-inflammatory mediators in the brain. Number three, it will help proper sleep. And we know that during the sleep, our brain gets cleared off from the inflammatory mediators. It has a better balance for the interleukins, like inflammatory interleukins. And also will have less of the like reactive oxygen species in the brain, that they are causing inflammatory processes as an ongoing phenomenon. When we have a better control as a mind over body thing, a better connection between the body and the brain, then we'll have better controlled breathing. We can have better impulse control. The impulsive behavior will be less disrupted. We'll have better sleep integrity. And we know that everything is to let go. So mainly for adolescents, when they are in this, very challenging transition into adulthood, and they always struggle with the external cues. When they have a better state of mindfulness, they will have better control on their emotions. They will have better cognitive emotion regulation, and that will help lessening of the buildup of the inflammatory mediators and the ongoing inflammation in the brain. As Dr. Vivek pointed out, most of the headaches are actually the inflammation which is already being built up in the head structure. They're actually head pain. They are not brain pain, right? Because brain does not have, noxious receptors. They're all responding to this inflammatory system in the CSF, in the vascular structures, in the meninges layers. So when we have a better clear off of those waste materials through the glial system and lymphatic system in the brain, based on the practice of ongoing, a proper mindfulness training, it is definitely going to be helpful in long run.
Thank you. Yeah, Dr. Diari,
So-
please.
Yeah, Dr. Vivek, as a part of protective or defensive medicine, so we are seeing a lot of pediatrician or physicians requesting imaging like CT, MRI. So what's your advice and how you approach these patients?
So I think most of my consultation is based on that because they have already gone through many of these discussions in the pediatric clinic. So as I said, the first part is starting from scratch, just not being biased just because the parents are saying it's a migraine or something there. As I said, it's always that big elephant in the room. Does my child has something intracranial which is causing the headache? So it requires 2 or 3 kind of consultation, a lot of things because Dr. Nami will also agree. It's not just the child, it's the parent's anxiety, which is kind of, reflecting on the child as well. My child has something, it's just like a functional disorder. And the child will have something, okay, they're bringing me to hospital a lot of time. There's something wrong with me or what, you're missing the school. And the first thing is just go back to the routine, send the child to, if I'm sure it's attention type headache, yes, we'll manage that. We'll give you the medicine. Let's do this, let's do that. So lifestyle intervention, treating the acute attack, if that works better, we'll see. If there's any change in the severity, if there's a change in frequency, that option is always open. That's how kind of, is my approach. I just don't finish that in one consultation. It's very, very difficult, believe me, because primary headaches are just diagnosed on history and examination. They always think that you will do some test and then you will come to conclusion. But that's how, opening the website, going through ICSD, why I'm saying that is not my something, I can do investigation in time. CT, of course, I avoid because unless it's very important in SAH kind of headache, we don't do CT to avoid the radiation. MRI is the choice of investigation. But again, any investigation, you have to have a clinical question in mind. What are we trying to find? What are we suspecting? If I'm suspecting, let's say, KRE malformation, you have to ask the radiologist. I'm suspecting based on the history, do I get that on imagination? Otherwise, there's no role in doing an investigation like a blanket investigation if you don't have clinical question in mind to do that.
On this regard, Dr. Vivek, sorry I'm interrupting. Many mothers, they come and they ask about the eye.
Yeah.
Should we check the eye? What is that? I mean, how much it contributes examination of all children with headache should be referred for ophthalmologic examination. In fact, I have seen some EEG also they are recommending. So what is your opinion regarding this?
It doesn't have any role in diagnosis or classification of the headache, of course. And the eye is one of the stress factor. If you have refractory error, if you're a lot to see, that can induce the headache as well. So as simple as having glasses or having refractory error ruled out, that's one of the thing. Of course, ophthalmologist, you cannot examine the fundus. That's one of the important part of. But if you're suspecting any papilledema or space occupying lesion, if your history pointing out to the secondary, your ophthalmologist is the best friend at that time. But a routine checkup is, in general, we say that all children anyway. But yeah, in headache, there's no harm in getting that done if it's a tension type headache, and definitely for secondary types.
And if I may briefly add to what Dr. Vivek pointed out, actually Dr. Vivek's thread of insight has been very comprehensive, but we still probably need to stress on some things which is not being that vertically covered during the discussion so far. So as Dr. Sohrab said, eye strain it's always something. It's different to the refractory errors. When we have problem with accommodation or astigmatism which is not being well corrected, and they have had some squint symptom signs during the examination, they might be having some ongoing diagnosis or probability for amblyopia. This might be causing some predisposing factors into the aggravation of the headache. One other thing that we haven't touched on in depth was the sleep disordered breathing, because children who come to the clinic and they have short neck, they're overweight, and they have a big collar size. And when you examine the back of the throat, the tonsils are pretty large, and the back of the tongue is wide based, and they have a propensity for having the risk profile for sleep disordered breathing, including obstructive sleep apnea or hypopnea syndrome, loud snoring, that might be causing some drops in the oxygen during those sleep hours. And when they wake up in the morning, they wake up with dry mouth, they wake up with morning headache. And when this headache is being treated by physicians and it's not going to get relieved, we always need to tap into the probability of sleep-related issues, specifically in those patients. When they have delayed sleep phase disorder, they sleep late, they wake up late, or they have sleep phase disorder in general. They sleep early, they wake up early, or they have fragmentation or patchy pattern for the sleep and wake habits. The other thing is regarding the quantity of their sleep. So when they have decreased total sleep time and chronic sleep restriction and sleep debt in children, that might be also contributing to the incidence of headache. And one last thing regarding the sleep, because sleep is a very wide issue, and we have 84 different types of sleep disorder that they might present at some level in children as well. But one of those things that they are kind of popular in our clinical observation is the TMJ problem that was also touched on by Dr. Vivek. And when they have bruxism or teeth grinding, they might be also checked for the TMJ problem. These are also interdigitated, and they might give rise to aggravation and perpetuating of the headache-related symptoms.
Dr. Vivek, there was a question from what other comorbidities associated with the chronic long-lasting migraine?
I think because migraine is a primary headache, most often, it's associated, and there are many studies to say they're linked with anxiety, depression-like symptoms. As Dr. Nami also said, these children can have neurodevelopmental issues like ADHD, but it's, one of the things which chronic headache, any headache rather than the migraine, can lead to anxiety and depression like thing. And you can't ignore that part, because unless you take a good psychosocial history, I've got some screening tools which I use, not like a detailed assessment like RCATS, or online tool, which can give me a hint of it's some phobias and the school attainment and their the attendance and so on. So most of the neuropsychiatry part, of course, you have to take the help of your colleagues in the neuropsychiatry and neuropsychology department to go in elaboration with that. But yes, you can do that with the history taking properly.
So Dr.
I think there is a
Saeed
question
asked,
from
Vivek, Yeah, sorry, ask after that. I'll
No,
ask.
no, go ahead, Dr. Zohar.
Yeah, in
Go
the
ahead.
classification of prophylaxis, I didn't see amitriptyline, although you mentioned later, but one of the drugs which is really effective for prevention. Amitriptyline, only the side effect is obesity. It causes weight gain, especially in ladies. What is your experience with that?
We've been using amitriptyline only in chronic tension type headaches, with a good dose, but very selectively use population who have associated kind of, the depression history as well, and along with the headache. But as I said, there was the head-to-head comparison with placebo, topiramate, and amitriptyline. Nothing was superior. And that was published, I think, just 2 years before in JAMA. Good analysis. But yeah, you can use amitriptyline cautiously in just chronic tension type. Migraine, it doesn't have much evidence.
What was cyproheptadine? I mean, propranolol is, I mean, why do you use cyproheptadine?
Amitriptyline, again, it's associated because the tension type headache pathophysiology is different than the migraine, because migraine, everything is towards anti-epileptic, topiramate, propranolol, and so on. Whereas tension type, there is nothing because the pathophysiology is so vague. We are targeting to the triggers, to the targeting to the comorbidities, to the depression, because you're just getting dull headache and it's just bothering you a lot. So that's the reason they have been using that. But as I said, there's no much evidence in prophylaxis of the tension type headache apart from the acupuncture. That's why we move very quickly to our psychologist colleague, to the alternative therapies and so on.
Please, Dr. Tyagi.
Yeah. The Dr. Vivek, there is maybe some questions again. A lot of children do not have a good breakfast, and this may be the cause of headache.
Yeah, skipping meal is one of the triggers for migraine. So that's one of the advice. Don't skip your meals. Yeah, because of migraine in the school.
Okay, and we are seeing a lot of headaches in patients with fever. So
And that's one of the secondary headache. If you see the classification, headache associated with viral illness, very vague. But just like in flu, you get cold, cough, headache, nausea, that's kind of symptom. So that's associated with the infection etiology. Of course, it'll go away when the infection goes away. But you have to be mindful of not,
meningitis. Yeah. So Dr. Zorab was in the history, he mentioned that vomiting is a cure of headache, and headache can cause vomiting. So what is how you explain this?
So as I was mentioning, migraine is associated with vomiting. In children, we get a lot of nausea. And if you stop that nausea, that's why I was emphasizing on antiemetic, kind of feel better. Vomiting, yes, it's one of the relieving factors if it's associated, but not in all children. We do get that once you vomit, once you sleep, get the better. But as I said, mostly the nausea is something to control. So it's not a kind of a treatment that you induce vomiting, of course.
Sometimes
This
if you use, it will
this thing,
increase the headache.
reflux is delayed. I mean, the gastric emptying time. Gastric emptying time is delayed. That time, that is why stomach remain full. Once they vomit, they
They get-
feel relief. I mean,
That-
Galen 2000 years back, even Hippocrates, they have postulated this.
Yeah, so that's not the pathophysiology. Again, we're discussing about the primary headaches. We're talking about the secondary gastrointestinal related headaches. Of course, that's the pathophysiology for that, the headaches.
So you said all patients should receive antiemetic also, along
Yes.
with.
You are really migraine, then yes, they should be getting this thing. If you are very sure about the migraine, yes.
Just as for the vomiting thing, like Dr. Vivek was highlighting in the list of the red flags in the couple last slides, vomiting was there, but specifically that becomes worrisome, that becomes a red flag when it is projectile, and that happens right after the wake up in the morning, and that's like persistent. So this is amongst the red flags, but other vomitings are actually kind of symptoms that are accompanied by the migraine variant headaches. We definitely need to take that into consideration if you all agree that projectile vomiting is something different, that like habitual vomiting, which is caused by the inflammation and the overactivation of the motor segment of the vagal nerve nucleus.
Dr. Vivek, is there a good way or how to assess objectively headache, not just subjectively, you know? If there is any scale, anything to do that?
Well, there are the scales which we use in the adult called HIT scales on the severity, but children it's very difficult. There is a scale for assessing the disability related to headache. It's something called PEDMIDAS scale, PAD-MIDAS. It just give the question, you know, how the lifestyle is affected, more of a quality of life like questionnaire related to the headache. That is something which we can use in pediatric population. But headache intensity scale or HIT scale is slightly difficult to use unless your child is over. So yeah, disability analysis we can use in some scales.
Is there a minimum age for headache? For example, we are saying neonates or toddlers or
But really, we do see children as young as 3, 4, and when they can tell that there is, you know, the headache,
they can help.
you know, assess behavior. So let's say meningitis related headache, you can get that in younger children as well, just because they are cranky and crying and, you know, they cannot tell about the headache. But when they are able to express, yes, they can tell the headache. There is no kind of literature thing to say there is a minimum for headache.
Final.
Dr.
Nami,
Vivek, I
can you
had
tell us
one
the latest
question.
sorry, sir. I was just asking anything latest related to headache and psychology as far as the, new advances, new development, which is coming up in future. It will come to the classification or treatment. Anything new?
Sorry, I lost that part. You're asking me, sir, Dr. Sharab?
Anything new which, in both aspects, psychological as well as, of course, new treatment, you said 4,000, 5,000, the new medicine that even tablet form has come. Just take one whenever you get, so expensive, nobody
Correct.
can afford.
Exactly. I've been asking that, you know, insurance coverage, if you are really good insurance, they can cover the lasmeditans and the Ayurvedic and so on. The most of the medication, those were 2000, they're very, you know, less used in pediatric population. Adults, they use left, right, and center, you know, with the chronic migraine, if you have good insurance. But we have very less experience in, again, they're licensed for 12 years and older. Neuromodulation also is very less often used, unless you are very chronic that. So yeah, a lot of research is going, especially in the migraine, because we have very clear pathophysiology and you can target the real kind of, you know, molecule or neuromodulators there. The psychology apart, you know, CBT, yes, that has good evidence, but of course, Dr. Nami can highlight.
Any role of surgery in future, like for the epilepsy, they do surgery for headache.
For secondary headache, of course, you know, is a big chunk of the headache, of course. You have to target the primary thing which is causing the headache, but not for the primary headache, not for surgery.
So one thing, Dr. Vivek, that I was going to add to the points you made was regarding the advent of neuromodulation in the treatment of chronic headache or chronic mixed headaches. We've had like at least 10 cases back in 2012 that we started testing the effect of neuromodulation in them using the non-invasive vagal nerve stimulation as well as the transcranial trigeminal nerve stimulation. And that was published in the year 2012 when we kept on doing that line of research. And we have witnessed recently that there are meta-analyses on the advent of neuromodulation for the treatment of chronic headaches. When the patient is reluctant or the parents are reluctant to go for the medicinal approaches, they might benefit still from this approaches, including the single pulse transcranial magnetic stimulation, non-invasive vagal nerve stimulation, and also TVNS or transcranial trigeminal nerve stimulation. These are actually being practiced in our current line of practice, so it's available now in Dubai. In case a patient would not respond, is intolerant or refractory to the medication therapy, or they would not respond properly to the CBT, then one of the remaining options could be letting them undergo neuromodulation and neurostimulation technologies. One question I had from you, Dr. Vivek, is that at what level will you be interested to run TCD to differentiate tension type headache from the migraine variant headaches? And is that a part of your routine practice that you go for the TCD? Because we have some differentiating signs that have been outlined in the literature. And to what level you clinically depend on those differential points?
I personally don't, and it's more of a research kind of interest as well. But clinically, if I know all my colleagues, even from London and practicing pediatriology, very rarely. We just based on the history and examination when it comes to children, of course, because it's very difficult and we focus on an examination only.
To Diari, Dr. Kalpana is not there. I know it is very late now.
She is
Tomorrow,
there, she is
Monday, they
there
want to.
because- Yeah.
No more questions.
No more questions, no.
So now, a question I asked about the Goa, nobody answered. Actually, Goa is.
No, answered. There was first one answered.
It was
William
answered as
Oh,
soon as.
after I said, I didn't see any.
No,
Now
I
this,
saw it. I saw it. Dr. Affan.
Yeah,
Afnan, Dr.
Goa
Afnan
that
Sheikh.
4 signs related to Goa. One is muscular weakness between Duchenne, which is a Goa sign. There is Goa syndrome, that is vasovagal, situational vasovagal syndrome. There is Goa tract, anterior cerebrospinal tract is named after Goa, and there is a Goa round. What is that? When he was in National Hospital for Neurology and Neurosurgery in London, he used to have one big round every week. That was called Gover's round. So these 4 signs are associated with of course, he has done a lot of work. The most famous is a Gover sign for muscular weakness, which we see in Duchenne. Yes, Dr. Kalpana, please.
Dr. Afnan Sharif answered. Yeah, Dr. Afnan Sharif answered.
All 4? Name or only name?
Just the name of the sign.
Okay,
Just the
okay.
name.
That what is the name?
Afnan Sharif.
So Dr. Tawfiq will give a token of appreciation. So we announce the name. At least we found a winner at least. But they are actually in adult neurology. In pediatric neurology, Tay-Sachs, the father of pediatric neurology from United States, they are actually in adult neurology. Yes, Dr. Vivek, Dr. Nami, last word, please. Last comments. Dr. Vivek is not there. Dr. Nami, please, last remark.
Yeah, sure. The most important thing that we can take from this thread of communication today, to me, was when to refer and what are the red flags. We have highlighted some key features, including the sudden, severe, thunderclap type of headache, headache with vomiting when it's projectile and mainly happening in the morning, the incidence of worsening or progressive type of headaches, persistent headache for the children specifically less than 3 years because they're not able to verbalize the headache efficiently. And also when the headache is there for months or weeks and with the significant unexpected weight loss, that also raises the red flag. When we have a headache in children and in the clinical exposure, we see neurological deficit or we see focal neurological deficit, that is also of salience. Headache with fever and stiff neck also raises the flag for meningitis. And also the headache with papilledema in the examination is also important. And last but not least, when we have headache in children that is accompanied by cognitive decline or personality changes, significant personality changes, this should also ring the bell for specific underlying mechanisms that they are playing part. So we need to go more vertical to do further assessments and analysis. And in those instances, we might be going for neuroimaging, different types of neuroimaging, including MRI, to differentiate that. One key take from the discussion was that there's always the value of the novel treatments. The treatments are twofold, either medicinal or non-medicinal / lifestyle changes. And we need to target the cause and treatment of the headache, not only focusing on the child himself or herself, but also with the help of the family, because family function and providing the atmosphere of support and also going for some brain-friendly lifestyle habits, sleep hygiene, and this and that. These are all going to be playing a part. And taking them all together, headache research is an evolving field of research, that there are many peculiarities, many unanswered questions there, and it's a very dynamic field of scientific endeavors these days.
Thank you very much. Dr. Vivek? Dr. Vivek is not there. Dr. Kalpana, Dr. Diari, please. Last. Yeah, Dr.
I think
Vivek
he's
joined
back.
us. Dr. Vivek, the last remark, please.
Okay, so I'll keep it very simple. The whole idea of this talk was to simplify the headache, the ODC, the emphasis on good history taking and examination. Even if you can classify primary and secondary, the half of the job is done, because primary comes, just the management. Then thereafter, I know sometimes it can be critical and very difficult to anxiety, but again, at least put the path. Secondary, of course, you have to target what is the cause, if it's dental, ENT, ophthalm, and so on. So I think I've given you the kind of the way the mnemonics and the history taking and so on. If we can classify and manage accordingly, migraine, tension type headache, and others, that is half of the job done. Thank you.
Thank you very much, Dr. Kalpana.
Thank you, Dr. Adi.
Dr.
The
Diari?
topic has been covered very well.
Thank you, Dr.
No,
Vivek and Dr. Nami and all the audience. Thank you very much for your attendance. Thank you.
Now I'd like to thank Dr. Vivek for excellent presentation, discussion, Dr. Nami for excellent comments and taking part in the panel, Dr. Kalpana. Dr. Kalpana was not feeling well. We requested she came, Dr. Diari and Dr. Tawfiq for sponsoring. I would like to thank all viewers who are with us. In other countries, it is midnight now. Still, they are following us. Thank you very much. Inshallah, in future, we'll have more webinars like this. Thank you very much and good
Thank
night.
you.
And our annual symposium will be on 22nd of November. Please save the date. See you there. We will have interesting sessions. Thank you and good night.
Good night.
Thank you, Alpine.